Okay, thank you again. So, nothing to declare, and, well, again, the same items. Parkinson's disease and BPH are very frequent concomitant diseases, and the use of alpha blockers is really interested because it offers limited but positive voiding improvement. And this is a paper by Cristiano Gomes from Brazil, which you can see that here all the aerodynamics and subjective scores, questionnaires improve with doxazosine between baseline and 12 weeks. So it's limited because there are no many papers this cited, but it's positive. But let's take a look. Because he uses the Unified Parkinson Disease Rating Scale, which is a toolkit in this. You can get it in the web in this direction. And this scale can predict the results of the doxazosine. So we can see here that we have responders and non-responders with doxazosine with different variables, and the only variable which is significant, statistically significant, was the UPDRS score. So if you have a score less than 70 points in this tool, if you have less than 70 points, you have a 3-to-1 higher chance of clinical improvement that scores those patients that scores more than 70 points. So this is very interesting work. And this, in contrast, when they study the aerodynamic parameters, they have no significant statistic differences between responders and non-responders. Because this is the same in non-neurogenic bladder. When we treat bladder outlet obstruction with BPH, with tamsulosin or the doxazosine, we don't see generally changes in the aerodynamics. So in this neurodegenerative diseases, it's just the same. Can be treated the patient with combination? Yes. With anticholinergic? Yes, as we saw recently, and be much care with the hypotension, orthostatic hypotension, which is already very common in PD patients, and especially in multisystemic atrophy. So moving, and this is the only studies we have with tamsulosin, with pharmacology. What about BPH surgery? Very few studies also. Urstuder, Roth, and Fowler have a retrospective study with Parkinson's diseases and BPH surgery, 23 patients, median age. They use this scale for Parkinson, and 14 patients have indwelling catheter, and they restored in 64% the voiding, and only 5 patients, 36%, require catheterization post-op. So, nowadays, Parkinson's disease is no longer be considered a contraindication for transurethral resection of the prostate. So we can do the surgery with this problem, with no problem. But always take care with the sphincter, because this is very interesting also, because if the patient with Parkinson's disease can contract the sphincter, rarely develops urinary urgent incontinence. So the patient with risk of postoperative incontinence is high in those who are unable to contract the sphincter ani. And this is a very old, 1988, study by Staskin and Siroki. And look at this. They have 36 patients, 30 with Parkinson, 30 continent, 6 incontinent. They clinically assess the voluntary sphincter control. If they can control the ani, the sphincter anal, if they can control the 30 continents, most of them maintains the continence. With incontinent previous patients, if they can control, they can voluntarily contract the sphincter, they achieve the continence. But the 30 continents who cannot contract the sphincter, they develop incontinence, and of course, these 4 patients' incontinence maintains the incontinence. So this is a very clinical, very simple clinical tool to predict incontinence and surgery in Parkinson's disease. If you don't, or if you can, sometimes the electromyography evaluation is a little bit more precise, but a clinical assessment with this contractility is very, very good. Now there is a consensus, between all experts that incontinence of MSA rarely improves after prostate surgery, and if there's a clinical suspicion in patients who we think that, or with diagnosis of Parkinson, but we think that there can be a multisystemic atrophy, please don't operate this patient, because you will not have good outcomes. And the useful discriminator, as I told recently, the useful discriminator for ITO is the post-void residuals. If they have 100 or 150 residuals, perhaps if you have a misdiagnosis of Parkinson, and you can think about this was a misdiagnosis of Parkinson and is an MSA, please don't operate this patient because they don't improve. We have seen that the open bladder neck is easily seen in the video aerodynamics, so this is another tool. And the most important predictor of multisystemic atrophy was the neurogenic change of electromyography in the sphincter, rarely seen in patients with Parkinson's disease. So, in dementia, we have very limited evidence, 13 patients, these ages. 4 of 13 patients have urinary retention. They have the complications, 1 acute myocardial infarction, multiple gastric ulcers and decubitus ulcers, and 3 died beyond 3 months, not for urological problems. So with the 10 patients, 26 months later, 6 patients reported good urination, 3 reported improvement, although they require intermittent catheterization, and 1 developed mild incontinence. So dementia is not so risky. And with very, very few patients, 4 patients with green light photovaporization of prostate with severe dimension, with this mean age, 81 years, the mean prostate volume 63, and flow increases very, very well to 18 milliliters per second. They diminish the post-void residual to 46 at 3 months. So no post-operative complications were observed, so we can offer green light PV in this group of patients. So conclusions, we can use alpha blockers. If you use the Unified Parkinson Disease Rating Scale, you can predict the results of the alpha blockers. The combined therapy is available between antimuscarinic and alpha blockers, but beware of orthostatic hypotension. Surgery and Parkinson is okay. Always check the external sphincter, clinically or by electromyography. Caution if you suspect multisystemic atrophy. You can diagnose this because with a high PVR or by video open neck bladder in video aerodynamics, and you can operate dementicide patients with no problems. Are there questions?
Thank you. There is any question about in the audience? I do have one. What is your personal experience? It's okay? Do you hear? Okay. What is your personal experience what to do with MSA patients? Because I do have an issue with treating over
obstructive people.
patients.
MSA have very, very high prevalence of orthostatic dizziness and hypotension. They can develop hypotension with tamsulosin, which is a very low prevalence of hypotension in the general population. With tamsulosin, they can develop hypotension, and I have very, very few patients with 1 milligram with terazosin, which is the one who is most hypotensive drug. But if you titulate to a very low dose, perhaps you can do well with alpha blockers. Very low doses of terazosin.
Have another question? Thank you. The microphone.
Yeah, I have actually two questions, if I may. The first question is, if you consider the side effects of the anticholinergic, of anti-muscarinic medicine, do you think it would be possible in the future that we use the beta-3 agonists as first choice?
For me?
Yeah, for the whole group.
A very good question. The patient have more than 65-year-old. I will start with beta-3 the first line because the patient have dementia. Already it's old. I start antimuscarinic have worst effect of so we can start. And also if the effect the results not so good, I go forward to botulinum toxin.
Yeah, and what do the other members of the panel think? Because it's just a question I was thinking about.
I use if the patient have no impairment of cognitive impairment, I use antimuscarinics. If I saw, and I prefer a low dose of antimuscarinic, 5 milligrams of solifenacin, plus 50 milligrams of mirapigram. If the patient has impairment, cognitive impairment, I use as first line mirapigram. And I always, if I am thinking about botulinum toxin, I prefer to operate the patient first, this surgery for this obstructive surgery, and then I use 100 dose units of botulinum toxin.
But you were talking about obstructive patient or not obstructive patient?
No, mostly the non-obstructive patients.
Do not obstructive patient.
Yeah.
So I'd rather start with agonist beta-3 too.
Yeah.
Yes.
So that's interesting because you all, as panel members, all think that, but it's still not in the guidelines.
No.
Is it because of a lack of evidence or long-term outcome measurements, or why do you think?
I think really have to wait long-term studies that may, with a great number, a great level of evidence that we can do or we not can do, but that then would appear in the guidelines.
Yeah, because it's already quite
So,
complex, I think.
Professor Castro has a comment.
Yeah, some antimuscarinic have been better evaluated in very elderly people, let's say like 80, 85 years than others. Do you have any preference for, if you have to prescribe antimuscarinic in elderly people, you have any preference for one? Because trospium doesn't go through the blood-brain barrier. Fesoterodine has been very well evaluated in elderly people, but 80, 85 years old, and it has been shown not to produce cognitive effect. So I know because some patients might, if they have hypertension, the use of miravigram might be reconsidered.
If I use antimuscarinic, I prefer solifenacin, which is the drug that has the less constipation. So I prefer solifenacin than darifenacin, and then solifenacin than oxybutynin. This is my first selection generally, if they don't have impairment, cognitive impairment.
And I may say that although the patient do not have a cognitive impairment, I'm not so sure that this patient have a healthy barrier hematoencephalic barrier whatsoever. I'm not so sure of that. So why they should? Because they're standing in neurodegenerative disease. So there are not enough clinical studies that tell me that of these patients that what is really the results of it.
Okay, can I ask my second question? Already a lot of questions for you.
I don't know. It's another price.
Okay, so I was wondering, in the presentations was also mentioned that bladder augmentation is an option. I think it's quite a big surgery, and many people with MS eventually can't handle catheters, so catheterization is a problem. I would suggest to prefer a breaker instead of an augmentation. What do you think about that?
How I said, there is exceptional indication. If the patient cannot do clean intermittent catheterization, we can consider a breaker or ileovasculostomy. Is easy procedure and the same effect of breaker.
Okay, thank you very much.
Thank you.
Ricardo Silva from Lisbon.
Okay.
I have, let's say, 2 questions and 2 comments about 2 specific diseases. One, it's MS, and it's about also the augmentation cystoplasty and how to treat these patients and how to diagnose them. Because I do think that we must always perform urodynamics and I would say video urodynamics in such a complex patient, such as a patient with MS, because we have to know how to treat the patient, and there is a great heterogeneity of urodynamic findings. So I always perform urodynamics and video urodynamics prior to any treatment in MS patients. And I do think that some patients with MS are maybe eligible for augmentation cystoplasty if the patient has good hand coordination and if the disease is severe, and the patient will probably benefit because Botox is not working anymore. So I do think they may be candidates, and I would like to know your experience.
You're talking about MSA?
About MS, multiple sclerosis.
Okay. Thank you.
Because I think I heard that urodynamics could be almost optional in a first-line diagnosis in multiple sclerosis patients.
Yeah. You are, in my opinion, you are right, but I don't like to perform any major invasive surgery or irreversible surgery in patients with multiple sclerosis because the disease might change. For example, nowadays there has been introduced new drugs that can stop the progression of multiple sclerosis. So I think that definitive surgeries or should not be performed in patients with multiple sclerosis. And in any case, regarding the previous question about bladder augmentation in patients with neurodegenerative disorder, I would agree with the lady that mentioned the possibility of breaker. I would rather go for breaker because these patients sooner or later will have this capability to perform intermittent catheterization. And if not, sometimes we have to use a permanent catheter, and we have to recall that it's always better suprapubic tube than transurethral catheter. So we all, urologists or gynecologists or doctors that deal with this group of patients have some of them with a permanent catheter. So even if we don't like it, and it's always better a suprapubic tube than a permanent transurethral catheter.
Okay, thank you. The second question was about Parkinson's disease and the bladder outlet obstruction in Parkinson's disease patients, because it's always a difficult question we all have in our clinical practice. I usually perform video aerodynamics in these patients because I think it's the most accurate way to see if there is obstruction at the level of the prostate or whether there is sphincter bradykinesia, and we see that there is a good filling of the prostatic urethra, and then we see the stop at the sphincter. So probably surgery may not be harmful, as you said, but it's probably useless.
Mm-hmm. Yes. You're right.
No.
So you are correct. The video dynamics help us much. Also, if you can add video dynamics with electromyography, you have both sign to verify just obstruction or have also bradykinesia.
Yes, I'm right. You're right. The video dynamics is extremely useful in Parkinson's disease as well. So it's okay. Thank you very much. Yeah.
Hello. My question pertains to the use of intravesical botulinum toxin in these patients. Our observation is that majority go into retention. If you had in one slide said that you decrease the dose to 100 units, but patients of MS and Parkinson disease still go into retention and they have to be counseled about the need of CIC. So how do you counsel your patients for that? Because commonly they fight that we were avoiding before and now we're on intermittent catheterization.
You always need advice that about 10% of patients become retention. I need to start clinical and catheterization. You need to teach the patient before inject botulinum toxin. And most of them, after 1 to 3 months, regain normal mixturation.
Secondly, in patients of MSA, do you advocate putting botulinum toxin in the sphincter as well if there's a documented DSD on the urodynamic?
No, I don't have experience with DSD, with toxin botulinum in the cerebral sphincter. So this patient with dysenergia probably go very well with intermittent catheterization if you have a good reservoir.
Mira, that's okay.
Thank you.
Do you have another question from the audience? So I thank you very much to all. Thank you very much for the professors that have been here in the presentation.